Okay, hi everybody. We are recording for training purposes and we'll be sharing this on YouTube later on after the fact. But I wanted to say welcome to you all to the Bertec Knowledge Series. We're doing a couple of webinars a month here. We've already hosted a few and we're excited to have you join us or join us again in case you joined us last time. The objective of this series is really to bring together clinicians of a variety of different disciplines, all in the world of movement sciences. And we like to highlight different research and different work that's being done clinically in that space and hope that will help you make applications and connections for your own practice. So today we have quite the treat. We have actually two people that are on staff here at Bertec. We're going to be covering the basics of eye alignment, convergence, and accommodation with our presenter, Dr. Charles Shearer. He's a neuro-optometrist. He has a practice in Indiana and has for many years. He also consults with Bertec on product development and education. He's a nationally recognized leader in vision therapy, visually related learning problems, and sports vision enhancement. So he's going to be presenting today, and as our host, rejoining us from Bertec, we have Dr. Fernando Santos. He's a PT and PhD, and he's our senior applied biomechanist at Bertec. So he has his hands in a variety of different initiatives with us and our strategy, and we're excited to have you both. So the way that this is going to work, like last time, is we're going to suggest that you ask your questions in the chat. We're not going to have cameras on or anything like that. Here, I'm going to admit all the people. Oh, you've got it right. There we go. People are still filtering in. So I'm going to play some pre-recorded content that Dr. Shearer has created for us. And during that recording, if you could just ask any questions that you have about the content in the chat. Feel free to ask anything that you're curious about as he's presenting. And Dr. Santos and Dr. Shearer will answer as many questions as possible in the chat. And then following that, that's about 20 minutes long. Following that, we'll have time for a Q&A at the end as well, where you can ask more questions in the chat. So I think that I covered it all. So I'm going to go ahead and share my screen and start presenting.
Good afternoon. My name is Charles Shearer. I'm a developmental and neuro-optometrist specializing in binocular vision, sports vision, and neural rehab. I'm honored today to bring you a presentation on convergence and how the eyes align and how accommodation and focusing all work together. I've been in private practice for almost 40 years, started when I was 12. No, and I also am a consultant to Bertec as their vision science consultant. The topic today is the basics of eye alignment, convergence, and accommodation. Basically, it's to help educate you and teach you how, when we look from near to far, everything works together. The goals of the presentation are to kind of define eye alignment terms, talk about convergence, accommodation, and how they work together, and then how they all relate to traumatic brain injury. Eye alignment is really broken down into two abnormalities. Either you have straight eyes or you have atropia, which means that one eye is turning in, out, up, or down. If you see in this first slide, we're highlighting the esotropia, and here the right eye is looking straight ahead, the left eye is turned in. With this example, the right eye is looking straight ahead and the left eye is turned out. That's exotropia. When you see this in a patient, it will be quite obvious. They walk in this way. Their eyes look, and always, most of the time, I should say, not always, will stay this way. They can also be a turning up or turning down of the eyes. That would be a hypertropia or hypotropia. This condition is a lot more rare, but most of the lateral tropias will have some vertical component. It's not that the eyes will turn straight in and straight out. They'll always be up or down a little bit. The second type of eye alignment is called a phoria. With a phoria, the patient will walk in, or the subject will walk in, their eyes will look straight, but they have a very strong tendencies for the eyes to turn either up, down, in, or out. So when they get real tired or fatigued or have an injury, they may drift. I'm going to show you what we call a cover test, or how to perform a cover test. And this lets you tell the difference between phorias and tropias. When the patient walks in with an obvious eye turn, you suspect here a right esotropia. If I cover that eye, nothing happens. If I cover the other eye, the dominant eye, that eye will turn in, and the eye that was turned in previously goes straight. As soon as we uncover, it goes back to that normal position. When it's a phoria, the patient will come in with both eyes looking straight. As soon as we cover one eye, it goes to its position of rest. In other words, it will turn in behind the cover. When we uncover that eye, it goes straight. When we cover the other eye, it will turn in. And then when we uncover it, it will go straight. This is quite different than when we see what we see in convergence. With convergence, both eyes stay working together, but when they look from a distance target to a near target, they'll converge. And that's usually a jump motion. They'll look from blackboard to book to back to the blackboard. And you'll see this be affected in concussions, as we'll talk later. Tropias and phorias can be either acquired or congenital. Kids can be born with crossed eyes. Sometimes it's because the nerves are telling the muscles the wrong thing, or other times it's because the child is very farsighted. And every time they go to focus, the eyes will turn in a little bit. The other types of phorias and tropias are acquired, and that can be from things like a sixth nerve palsy, a traumatic brain injury, such as a concussion or a stroke. I'll show you how you can see your own phorias here. If you look at the screen, the X that's going to come up here with both eyes. Oh yeah, it's phorias, not phobias. So what I want you to do is stare at the X with both eyes and then cover either eye. Let's say you cover your right eye. As you cover that eye, it will go to its position of rest. When you move your hand to the other eye, that X will jump. If it moves in the same direction as your hand, the eyes were turning out. And that's because behind your hand, the eye went to its position of rest or turned out. As soon as you moved your hand to the other side, that X will jump in, or the eye will jump in to look at the X. So as you go back and forth, if that X is jumping, then your eyes are not lining perfectly straight. The more it jumps, the more your eyes tend to either turn in or out. If your eyes tended to turn in, when you moved your hand from left to right, the X would actually jump in the opposite direction. So what happens when we look up close? Every time we look far away, our eyes go straight, are supposed to go straight, and relax focus. Whenever we look up close, we want those eyes to team together or work together. So obviously we want both eyes working together, not just one. So there are three things that have to happen. We have to cross our eyes to line them up on the target. We have to shift focus to make the target clear. And as we do that, the pupils will constrict or get smaller in order to increase depth of field. And these things are illustrated in this graphic here. You'll see on the bottom, we've highlighted the medial rectus muscles, which are the ones that help our eyes turn in. When the nerves tell those muscles to fire, the eyes will cross, but simultaneously they have to tell the lateral rectus muscles to relax. If we go straight up from there, you'll see that on the left, the pupil is bigger than the one on the right, and that's because with accommodation or focus, that pupil will get smaller. You'll also notice where it says focus there, that there's the ciliary muscle that is responsible for accommodation. And as it flexes, it changes the shape of the lens internally on the eye. So all three of these things are connected and have to work together every time we shift focus up close. Notice in this graphic that the middle normal convergence arrow is where the eyes should be focusing. Sometimes the eyes will overcross or converge to an excess and they'll cross in front of the object. More often, particularly after concussion and brain injury, the eyes will underconverge, and this is called convergence insufficiency. And this happens in a high number of post-concussion patients. It's the number one visual symptom and probably the number one symptom overall. And we'll show you how this works here with this little animation. Each time that you look far away, the eyes go straight. As you bring a pencil towards them, they cross a little more. They cross a little more. And what we're looking for is the point at which they cannot cross anymore. At that point, the dominant eye will stay looking at the target and the non-dominant eye will go straight. When we do this, it's rarely tracking in. It's almost always a jump. We're jumping from near to far and back. So our eyes do this hundreds and hundreds of times a day. With convergence insufficiency, they just don't cross enough. With normal convergence, they're going to line right up very exactly on the target. The next part is accommodation. That's a fancy way of saying focus. Every time we focus, that muscle causes the lens inside the eye to change shape. When we get to be in our 40s and 50s, and some of you in the audience will relate to this, that muscle doesn't work quite as well, and that lens gets a little more rigid or less flexible. So our arms get too short. We push things out in order to be able to see them. So when we measure accommodation or focus in a patient, we have to keep their age in mind. With convergence, convergence does not change much with age, actually very little. One of the things that we see in post-concussion is something called a lag of accommodation. What that means is that instead of very accurately focusing on the target they're looking at, they're a little lazy with their focus. In other words, we'll put up with a little bit of blur to not have to focus so exactly. In normals, that's about a half a diopter, and a diopter is simply an optical unit of measure. So that's normal. Unfortunately, in accommodation problems post-concussion, that can be a diopter, 2 diopters, and under focus quite a bit. And that brings us to the topic of ACA ratio. Remember, I said that all of these things are tied together. You can consider them to be almost hardwire. Every time we shift focus, there's a signal sent to the medial rectus muscles to turn in. Every time the muscles turn in, there's a signal sent to the accommodation as a feedback to tell them to shift focus. If the eyes are converging too much and you put reading glasses on them, they'll be doing less focusing, so their eyes will go straighter. And we use that a lot with children who have crossed eyes. Unfortunately, post-concussion, many patients have convergence insufficiency. In other words, they're not crossing their eyes well enough, but they're also not focusing well enough. So the tendency for some eye doctors and some occupational therapists and physical therapists as well is to tell them to get a pair of reading glasses. When they do that, when they put plus lenses or reading glasses in front of that patient, their eyes don't have to focus as much, so they'll actually not turn in as much. And remember, convergence insufficiency is not turning in enough to start with. So when you put those lenses on, you'll actually make the problem worse. So we have to be very careful when we give a patient reading glasses. We often have to include something called prism in there, which causes the eyes to not have to turn in as much, by moving the object out to where the eyes are. In other words, we're bringing the mountain to Muhammad instead of the other way around. So reading glasses without prism can actually help clear things up that make their eyes turn out further. The third part of the response is the pupils. And I'm not going to spend a lot of time on pupils today because that's a whole topic on its own. Basically, any traumatic brain injury has the potential to cause damage to the neural structure between the two pupils. So what we want to look for if we're checking pupils on a patient, particularly after a head injury, is we want to see perla. That means that the pupils are equal, round, react to light, and accommodation. So in other words, we don't want more than 2 millimeters difference between the two eyes. Even a millimeter is often significant, but certainly 2 millimeters of difference would signal some damage. They should be round. If they're out of round, the eye itself may have gotten hit, damaging the sphincter muscles in the pupil, causing them to be irregularly shaped. And of course, both eyes, when you think of pupils, you think of the light constricting the eyes. So if we shine the light into the left eye, not only will the left eye constrict, but the right eye should constrict an equal amount. And when we swing that flashlight over to the other side, we expect to see the same response. The thing that people don't look for very often is the response to accommodation or focus. So as you're evaluating if the patient can converge or focus their eyes, you not only want to look at are their eyes turning in, but you want to look at the pupils to see if they're constricting as the eyes are turning in. If not, that suggests a problem. Now, why is all this important to concussion? There have been many studies done, and the one I like to quote the most is the one by Dr. Kafrida at SUNY. They looked backwards at brain injury. Now, that was both traumatic brain injury and mild traumatic brain injury or concussion. But when they looked at clinic records, 90% of patients with TBIs and 87% of patients with a stroke will have some sort of ocular motor dysfunction. This means that either their eyes can't focus, they can't converge, they can't track properly, they can't jump from one word to another, which is what we call saccadic eye movements, or they may have a strabismus if the nerve is damaged, as in a sixth nerve palsy. When we talk about these findings, you need to really look at the eyes every time you're doing a post-concussion evaluation. Ocular motor dysfunctions will often clear up naturally just with time in about 6 to 8 weeks. And that's true of about 2/3 of the patients. If you see no improvement during that time, or they're persistent after that time, you really need to refer them to a neurooptometrist or someone specializing in this area, because it's time to do therapy. And here's the statistics I was quoting before. Depending on the studies you want to look at, almost 54 or higher percent will have convergence insufficiency, 50% will have trouble focusing, 40 to 50% will have a photophobia or sensitivity to light. About 1/3 of them will have trouble moving their eyes with reading. And about another 1/3 will have what we call vision motion sensitivity. And that's when things in the peripheral vision really start to bother them. They can't walk through a grocery store without it upsetting them. The other thing to remember is that these things rarely occur in isolation. Most patients will have more than just one of these problems. So you need to look at all of them. Dr. Padula came up with a term that he likes to use called post-traumatic vision syndrome. And in that, many of these patients who suffer these disorders will have the combination of these things that we show here. They can't cross their eyes, they have trouble focusing, they have trouble moving them properly. They're often very sensitive to light. And they also have something called midline shift, which is, again, a topic for another day. But basically, they don't perceive things in the right place. When their eyes aren't lining up, it sends a false signal of depth perception to the brain. Things that I'd like you to take away from this presentation is what is convergence and how it relates to accommodation. You're going to see convergence problems in a large number of your traumatic brain injury, mild traumatic brain injury, and stroke patients. It's the first thing you should look for. 3 things that are involved in shifting focus are convergence, accommodation, and pupil response. Those things all happen together. So when you see a problem with one, it can affect the others. And that these 3 things are hardwired together. The convergence loop in the brain goes from the front of the brain to the back of the brain, to the midbrain, to the lateral geniculate body, and then out to the eyes. So it's a very long loop. It goes through almost the entire brain. So any damage to the brain has some chance of affecting that response. And that's why we refer to convergence as the weak link of vision in concussion, because it's the first thing that we see in most patients. Thank you for listening to me today and participating in this. And at the end of this, we will open it up for questions and answers. Hopefully, I'll have all the answers to your questions. Thank you, and we hope to see you in future webinars that we'll be putting on.
Hello, everyone. First of all, thank you, everyone, for staying here, for listening to the whole webinar that Charlie put up for us. It's a really important theme nowadays. We all know there's a lot of research in concussion, a lot of research with vision. We usually here at Bertec, we talk a lot about multi-sensory integration and all those kinds of systems and how we have to integrate everything. And vision is one of the most important of them. That's why we have Charlie here with us. So I haven't seen any question for you guys there. I'll start with some questions to see if you guys get a little bit less shy and come with some questions too. So Charlie, you talked about prisms. So can you tell me a little bit more about prisms? Like what are prisms and how much of them you have to use?
Well, prisms basically typically have, they're narrow on top and thick on the bottom. So we call them an apex and a base. And they just simply bend the light. So it'll move it any direction that you want, up, down, in or out. And the amount that you use, of course, is related to the amount of the turn or what you're trying to accomplish. Sometimes the prisms are used, and a lot of times they're used either what we call base in or base out, which means we're trying to affect convergence or divergence. But the other use for them, particularly in rehab and midline shift in particular, is to put them as what we call yoked. So we'd have them both base right or base left, and the patient has to adjust for them because it'll shift their whole world one direction or the other. And they're used also with autistic children to affect gait, and they're really pretty powerful. And the amount and to use takes a lot of experience, and some of it's seat of the pants. But basically, we don't want to do all the work for the patient. If their eyes are turning out 12 degrees, we may give them 4 degrees of prism because we want their eyes to do the other 8. Otherwise, if you correct it all, they'll what we call compensate, or the next time you see them, they're going to need even more prism. So
pretty good. So we have a question here. Sorry. Can patients progress away from prisms?
yes, I explain prisms to patients like you would with crutches, that they're a necessary evil to start with. Sometimes we have to keep them, but they're basically a crutch until we can do vision therapy and get them rehabbed back to the point where they don't need the prisms. So our goal is to, often we have to give them prisms to start with, and as therapy progresses, we'll reduce that. And, 6-nerve palsy is another good example. I mean, I've had prisms, I've had to put 30 and 40 degrees of prism on patients, which is a lot. I mean, that is a huge thick lens. And then 3 weeks later, it's down to 20. And then a week later, it's down to 18. And then eventually, as the pathways heal, it'll get reduced down. So they're powerful tools. I noticed one of the questions that popped up was, can therapists use yoked prisms? That's an individual state kind of rule that you need to check. And I would check with the optometric board. Most optometric boards, most states have a rule that only optometrists or ophthalmologists can use lenses or prisms. So if you're using lenses and prisms, you should be doing it under the auspices of an eye care specialist. Yoke prisms, they're a little bit more debatable because they shift things one direction or the other, and they're more used for rehab and not put on permanently, but it does vary state by state.
Great. So we have some questions there. Charlie, if you want, you can just...
Let me pop them up here. Okay, let me take the one from Natalie. Where can we find specific guidelines for introducing Brock string exercises and the best practice for progression and exercise parameters? Oh, that's a good question and a tough question, because, we like you, every time I'm at a lecture, someone always makes a statement: when you've seen one concussion, you've seen one concussion. In other words, it varies so much from patient to patient. But the Brock string does not utilize prisms or lenses. It uses what we call physiological diplopia, which is a nice way of saying normal double vision. And a good way to illustrate this for people who are not familiar with the Brock string is if you simply hold your finger out in front of you and line it up with an object across the room, like a doorknob. When you look at the doorknob, you're going to see two fingers. When you look at your finger, you're going to see two doorknobs. Well, imagine that those beads on that string are like the doorknobs and the fingers, that everywhere you're looking is single, everywhere you're not focused on is double, but you don't notice it because your brain's adapted to it. So the Brock string is a string with usually 5 beads on it, and we line those beads up so that they can see one single bead at a given distance. Let's say it's 20 inches from the nose. And then we're going to put some of the beads in front of them and some of them behind that, and have the patient jump from bead to bead. Where you start those beads really depends on whether the patient is exophoric or esophoric, or do they have a vertical phoria, and it varies a lot. And it's kind of funny, it's a $5 device and something patients can make themselves, but it's one of the more valuable ones that we can use. So I don't know, I hope that answers the question. I know it's kind of vague, but it really is very dependent on the patient. Looks like another question that says, I find that the use of a maddox rod is much more sensitive to detect subtle phorias. Do you use the maddox rod in your practice? And there's a reason that I did not mention the maddox rod. I use the maddox rod, maybe 20 times a day. I use the maddox rod on every patient, and we use it to measure phorias more exactly. The only reason I didn't mention it is that it's not a typical tool that most people would have. And I'd be more than happy if we get enough requests. That's one of the things we're looking for here is future topics. We can get into how to measure phorias and how much phoria is too much phoria and that type of thing. It's just a very big subject. So I compliment you on the fact that you know what a maddox rod is and you know how to use it. It's a very useful tool, and it will show you very exactly what a patient's phoria is. What it does, by the way, is it is a device, a piece of plastic that when you look at a light through it, it makes a streak or a line. And the streak is seen by one eye and the light by the other. And then you can measure how far the line is from the streak in prism diopters. So yeah, it's a very valuable tool.
Okay. Let's go to the next one. Actually, let's go up to the older ones.
Yeah,
right?
I started moving up on the top there. Let's take this from Dr. Walton. If a patient with CI and accommodative insufficiency presents with the need for reading glasses prior to their TBI, should they continue to use the same number of plus during the near work? The simple answer to that is yes. I wouldn't change anything too soon because it may improve just from time alone. If they're already using plus, let them use it. If they have to, and I should have mentioned this before, so thank you for asking this question, but sometimes we have to give them plus. They have to be able to see or focus. When they do that, again, we're going to make the eyes turn out even more. And a very simple way to help them with that is to cover one eye. So they're better off seeing clear with one eye than clear doubled or blurry. So sometimes when you put the plus on there, you'll clear it up for them so they can read their text or look at their phone and do things. And to avoid the double vision, you're just going to have to occlude or patch one eye. And then be sure to switch the patch from eye to eye when you do that. I mean, don't let them read 1 hour with the right eye and forget about the left one. You know, every 10 minutes, switch it to the other eye so both eyes are working. But yes, I wouldn't change the amount of plus until they've had an evaluation, and that plus may change with therapy or time.
Nice.
And let's see, yoke prisms we talked about. From Natalie here, which binocular vision disturbances are most likely to interfere with potential for recovery and vestibular rehab? When are the VOR exercises not likely to help with regards to the presence of visual alignment deficits? Thank you for asking that question, because our seminar next month, I'll put in a plug here, is on the eye doctor's perspective of VOR exercises. So the question you just asked is next month's webinar. But any kind of binocular vision dysfunction is going to interfere and affect vestibular exercises, but particularly vertical phorias are really tough. You know, the eye's used to all day long diverging, converging, diverging, converging. So that pathway is there. But when you have a vertical misalignment of the eyes, what the person does, and look for this when they come in, is they'll tip their head to compensate for that vertical phoria. So I can level my eyes out by tipping my head. Well, you guys know better than I do what that does to the vestibular system when we rotate the head to adjust for the eyes. Now we've upset the vestibular balance. So yeah, to answer your question simply, the vertical phorias would probably cause the most disturbance, but they're all bad. I mean, they all interfere with depth perception or fusion. Double vision is just terrible for patients to adjust to, and that's why we end up sometimes, if we can't fix it with prisms, we will cover one eye. So let's go on down. What are your thoughts on the validity of vision therapy provided by optometrists for these sorts of issues? It's been a was somewhat controversial years ago as to how effective vision therapy was, but for anyone who doubts the effectiveness, there's a study that was done called the CITT study, and it has been published not only in optometry but OT, PT, neuro, ophthalmology, and everything else, and it shows the effectiveness of vision therapy, specifically towards CI, which is the majority of these problems. It's up in the 90% range as far as effectiveness. Now, some people will simply give a patient push-ups to do, where you take a pencil and bring it up to your nose, push it back out, and that's a very valid exercise we give all patients. But if that's the only thing that you did, then the success rate is about 10%. If we do the full rehab of vision or vision therapy, the percentage of improvement jumps up into the 80 to 90%. Now, again, sometimes there's such a severe damage to a nerve that you can't rehab it. But vision therapy has been proven with studies, several studies, but the most accepted one, you can just Google CITT study, and I encourage you to read that.
So the next one is about the Brock string from Donna.
Right. When is it optimal to start a Brock string exercise to avoid focal binding? You know, I mentioned that a lot of binocular vision problems will improve with just time alone, and that if they haven't within 6 to 8 weeks, you definitely should make a referral. If there are any optometrists in the group, or when they see this, they'll probably send me nasty letters, because it really should start much, much sooner than that. But as an OT and PT, you're already working, and athletic trainer and physicians, I don't mean to exclude anyone of the group here, but you're already working on so many things, and you're doing an initial evaluation. And most of the OTs and PTs that refer to me and that we work with, and I have to say work with, you know, we're in communications back and forth, and when they're already visiting the OT and PT, I'll have them do some of the exercises so they don't have to make any more visits. You know, our goal has to be to help the patient, not our bottom line. Sorry for that political statement, but I do that once in a while. But to answer your question, the sooner the better. Bad habits are hard to break when patients compensate by doing head turns and these things. That can cause problems. But the Brock string is a very simple exercise to use, and it's very difficult to do any harm with that one. So I would tend to start that sooner. But if you really feel that there's that much of a problem, please consider a referral to a neuro-optometrist or ophthalmologist for workup. And the next question was the one we'd already answered on Brock string, and then maddox rod. Is there a best way to ID focal binding, and what are the best starting treatment and strategies? You know, it's a combination of a lot of things. It's like when you're doing a workup for, you know, a left side paralysis. I mean, there's not just one test that you look at. I mean, you do a lot of different things. So when we're trying to identify these problems, there's no less than 8 to 10 different individual tests that we do. And hopefully, if you take nothing else out of the lecture or the webinar, it's that accommodation and focus or accommodation, which is focus, and alignment are interlinked. So when we want to look how a person's focusing, we have to look at how their eyes are aligning, because the two are just hardwired together. And then we haven't even talked about, and again, it's another subject for another month, but perceptual differences. You can have the brain getting all the right informations, but if the damage has been to the frontal lobe and it's a cognitive effect on that, they're not making the most out of that information. So you really need to do a wide variety of tests. So that's, again, one of those questions that's kind of hard to answer without having done all of those tests.
Okay, we'll go for, there's just, I think, 2 more questions there. So we'll go for those 2 and then we'll close. And Alyssa will talk to you guys later too. If you have more questions, she'll tell you where to send them. And we like to keep in communication with everyone, right? And help as most as we can. So Charlie, the next one is from Margaret. It's a big text there. I'll let that for you.
And it's a great question. I love these questions because it shows me what I missed in the presentation. But when you saw that animation that I made where when the eyes can no longer converge and one eye goes straight, most people will say they see double. We have a lot of people who suppress one eye. In other words, instead of seeing double, the brain says, nuts to you, I'm going to ignore one of those eyes because double vision is the most disturbing thing to me. So you can see that the eyes are not aligned, but they don't see double, and they're not pulling your leg, and it's not a deep-seated perceptual problem, because normals will do that same thing. That's where you have to balance the objective measurements that you're seeing and taking with their subjective responses. Don't be surprised. The way that we get away from that is we use binocular targets. And in next month's presentation, again, we're going to talk about the targets that you should use in evaluating things, particularly in relation to the VOR exercises. So stay tuned. There's another plug for next month. And then finally, how do you distinguish a visual field cut versus neglect when both are present post CVA and TBI? You know, the difference is with one, they don't have damage to the actual neural fibers in the eye, but they have a perceptual neglect, or they're avoiding that. And it's difficult to distinguish between those two. We do sophisticated visual field tests with different lighting situations, and there's a lot of different ways that we can evaluate that, as well as, you know, you look at the whole picture, the MRIs and everything else. So neglect can be fixed, or excuse me, can be worked on and trained. A visual field cut can't. So for instance, we have patients who have pituitary tumors who have a very unique visual field loss called bitemporal hemianopsia, where they've lost the outside of both fields. You will not typically see neglect in that way. It's usually going to be one side or the other. So you have to look at what the field losses are, and first of all, see if they make sense, and then look at the overall physical picture.
Nice. Well, Charlie, thank you so much. I think this was really informative. It was a really good webinar. Every day I talk to you, I keep learning a little bit more about vision, what is really good. Alyssa will finalize here for us, but Charlie, again, just thank you so much.
Oh, you're welcome. Thank you all for joining us today.
Yes, thank you both. That was a great presentation, and the questions in the chat were fantastic. So really appreciate everyone's participation. You really really came in strong there after the presentation. So thank you. We have a lineup that I wanted to mention as well. The next few webinars we have lined up are on Wednesday, April 28th. So in just 2 weeks exactly, we're going to be joined by Dr. Stephen Thomas, who's the chair of the Department of Exercise Science at Thomas Jefferson University. He'll be doing a presentation on a clinical guide to pitching mechanics and kinetic chain deficits. So that'll be really interesting, and we hope that you can join us for that one. We also have another webinar lined up on May 12th, which is TBD, host and topic. We're lining that up now. And then Dr. Shearer plugged his next webinar, which is on May 19th, where he'll talk about VOR exercises from an eye doctor's perspective. So it sounds like that was relevant for a lot of you. And we, as Dr. Santos mentioned, we would love to hear from you, any questions that you didn't get answered today, and also suggestions for future webinars and future researchers and clinicians that we should be talking to and giving a platform to share their research and their work. We would love to take those suggestions. You can reach us on all the major platforms at Bertec HQ, so Twitter, Instagram, LinkedIn, and then we have our YouTube channel where this video will live along with the other webinar videos. So if you missed any piece of it or want to share it, that will be up within a few days. So thank you all. So yes, something?
Sorry, just for everyone, I put the link of our Twitter and YouTube channel on the chat, so you can go ahead there too.
Perfect.
And I'll add a link for that CITT study because it's a very, very good study, very valuable.
That was a great suggestion. Thank you all so much, and we hope to see you next time. And feel free to reach out. We'd love to hear from you. Thank you all. Bye-bye.
Stay safe.